Hello, everyone, and welcome to the Down Syndrome Center podcast. As always, I'm your host, Dr. Kishore Volodi, and today we have two great guests that are going to be able to come on and give us an update on a very important topic, and one that I'm sure we'll be hearing about as being very common in our population, both in pediatric and adults, and that is going to be talking about sleep apnea. So I'm so excited to have Dr. Rachel Whelan and Dr. Ryan Soose on the podcast with us. Before we get into the meat of this podcast, I'd love for you guys to introduce yourself. So, Rachel, we'll start with you. Go ahead and tell us who you are, what you do, and what draws you to this population.
Thanks so much for having us on your podcast. We're so excited to be here. As you mentioned, my name is Dr. Rachel Whelan. I work out of the Children's Hospital of Pittsburgh, and I am a pediatric otolaryngologist, which means I take care of children with ear, nose, and throat problems. And I also really specialize in the management of all children with obstructive sleep apnea and other sleep disorders.
Awesome. Thank you, Rachel. And Ryan, how about you?
Thank you, Dr. Velody. Yes, I'm Ryan Soose. I'm a sleep medicine physician and an otolaryngologist or ENT surgeon with UPMC. I work out of the UPMC Mercy site primarily and have run our multidisciplinary sleep program there for about the last 15 years. And like Dr. Whelan, I'm double trained, double boarded in both sleep and ENT, which allows us both to really provide, all of the tools in the toolbox for these patients.
Yeah, and thank you both for what you do because honestly, it's something that we rely on both of you, on whether we're taking care of kids or adults, to be able to help our patients. Sleep apnea is something that we know is common, and we're going to be talking about that here during the podcast. But Rachel, why don't you start us off? Just give us a little bit of basics. Like what is obstructive sleep apnea, or OSA, we'll sometimes call it, and why is treating this important?
So OSA, or obstructive sleep apnea, really refers to the idea that there's these repetitive pauses in your breathing over the course of the night. And this is really, if you can imagine, the back of the throat, basically something kind of falls back and blocks the air from getting down.
Hmm.
And so you can imagine these patients with OSA go to take a breath in at night. Literally something falls back and blocks the air from getting down. Their body wakes them up just a little bit to kind of clear that tissue out of the way. They fall back to sleep, and that process happens over and over again all night long. So you can imagine that it's not too surprising. It's putting extra stress on your body over the course of the long term. So in the more immediate term, you end up just not getting a great night's sleep because you have all these small awakenings all night long. You can imagine if somebody's waking you up every few minutes all night long, every single night, you're never really getting that good restful night's sleep. And then over the long term, we worry about the extra stress it puts on your body. So we see an increased risk of heart rhythm problems, which could even lead to stroke risk. And we see an association with problems like diabetes and high blood pressure as well.
And is this something that we would see in children as well? Like, what is it about Down syndrome and kids with OSA? What do we know about the connection between the two?
So when we look specifically at kids with sleep apnea, we know it's really common in kids to snore. So I guess, all of these things with sleep are a spectrum, right? And so snoring is super, super common. When we look at the kind of overall population, we think about 2 to 5% of kids actually have this blockage in the back of the throat, meet the criteria to be called sleep apnea instead of just the snoring. And when we compare that to children with Down syndrome, we see that over 50%, almost, 3/4 of children with Down syndrome also meet criteria for sleep apnea. So it's super, super common. So we think that kids with sleep apnea are anatomically at much higher risk for having sleep apnea. They have larger tongues, they have overall smaller noses, narrower jaws, a little bit higher on the body mass index scale, and then are at risk for having lower muscle tone or hypotonia, which all increases risk for sleep apnea. And really because of this, when we look at the American Academy of Pediatric guidelines, they recommend a sleep study by about 4 years of age. And then after that, yearly monitoring for any signs of sleep apnea in kids.
Yeah, whenever we think about sleep apnea, like folks who do the kind of work that I do, and we are, following the kids and sending them off for sleep studies, people will say sometimes like, the number 75%, 80% will have sleep apnea, and I've heard others make a joke that the other 20, 25% just didn't have a good sleep study that night or something like that. So it's really, really common in our kids. And so definitely, okay, we're going to pause there with the kids part of it, and I'm going to see now, Ryan, yeah, I'm a pediatrician. I don't know much about adult issues in sleep apnea. I mean, do we see this in adults in general, and also are we seeing it more commonly in adults with Down syndrome as well?
Yeah, it's both to your
Yeah.
point. So I think part of it is the increased recognition of it, the awareness of the problem and how it affects people's quality of life and relationships and families, how it affects their brain health, their heart health, and so forth. But part of it is increasing because of issues with people's allergies and enlarged tonsils and overbite or orthodontic issues. And one of the biggest things is just the overall weight gain of the population over the last several decades.
Mm.
That weight gain contributes to more tissue in the neck, more tissue in the tongue and around the throat, which to Dr. Whelan's point then narrows the breathing passage. I think specifically, one of the other things I think is important to understand in patients, adults with Down syndrome, is that not only are they at higher risk of having sleep apnea for the reasons that Dr. Whalen pointed out, but they're also most vulnerable to the side effects. So adults with Down syndrome have been shown to have higher rates of early onset dementia
Hmm.
and cognitive dysfunction. We know that untreated sleep apnea worsens brain health and cognitive function. Adults with Down syndrome have high rates of congenital heart disease, right? At least half have some structural heart disease. And we know that untreated sleep apnea puts more strain on the heart. So it's a fascinating situation where both kids and adults with Down syndrome are at higher risk of having the condition because of certain anatomic and physiologic factors, but they're also more vulnerable to the side effects. So they need better treatment options, maybe more than anybody else.
Mm. That's really, yeah, really important point, how it all kind of plays together and how we can help with prevention of some of these things. I think that's really great. Now, so you both mentioned that it's common. It's common in kids. It's more common in adults with Down syndrome than in the general population. And I guess it's one thing to know something's more common. It's another thing to know if there's something we could do about it. So why don't we shift and start thinking a little bit more about what might be things that we could do. So Rachel, tell us from a pediatric perspective, what can we do for kids with Down syndrome who have sleep apnea?
So I know Dr. Soose and I are biased because we treat this disease for a living, but when you think about what's actually driving sleep apnea, the fascinating thing is that it's literally different for every single patient. So every patient is just kind of built differently in the back of the throat. And so the different things that are collapsing and causing this obstruction at night is different in every single patient.
Hmm.
So really treating the disease is completely individualized for every patient, which is different than the way we think about and treat a lot of disease processes.
Yeah.
So when we think about kids with sleep apnea, the overwhelmingly most common reason to have sleep apnea in kids is big tonsils in the back of the throat and big adenoids in the back of the nose. And so removing those, if they're big, is usually where we start with kids. And then once we remove those tonsils and adenoids, really that becomes, the next question for the kids that still have sleep apnea and are still symptomatic.
So you're saying that sometimes you might take out the tonsils and adenoids and you may not see a complete improvement. Because I know that in sleep apnea in general in kids, usually tonsils and adenoids are pretty curative. Well, what would you think in terms of in somebody with Down syndrome, how often are tonsils and adenoids alone enough to really take care of the issue? And how often are you finding you have to do next steps?
Yeah, Dr. Velody, that's exactly right. You're hitting the nail on the head. So in children with Down syndrome, we see actually about half of kids have a great response. Sleep apnea is basically cured,
Hmm.
which means the other half of kids still have some degree of sleep apnea, which is a huge number. And so really that's where we kind of start thinking about what else can we do to treat this? And really the question at that point is usually, do we consider other surgeries? Is there something else, soft tissue wise along the upper airway, the nose? Is there an allergy component like Dr. Soose was talking about? Is this really being driven by weight? Can we work towards healthy diet, lifestyle, exercise choices? Or do we even consider a CPAP machine?
And so as we think about the kids and as we're managing that, I know we're going to be talking about other devices that have come out recently here as we move on in the podcast. But before we get there, Ryan, why don't you tell us a little bit about adult sleep apnea? What's your perspective when you see an adult with Down syndrome who comes in with sleep apnea? How would you manage that?
Yeah, there's similar parallels. I think the progression of treatment options is a little bit different in adults. There's a little bit more of a focus on maximizing the medical therapy options first.
Okay.
There are newer, better, smaller, quieter CPAP machines now. There are a lot of custom dental devices and orthodontic work that can help weight loss. In fact, one of the GLP-1 weight loss medications is now FDA approved for severe sleep apnea. And we still take out tonsils and work on deviated septums and other structural things. But as a general rule, we're trying to customize, as Dr. Whelan said, a personalized plan to each individual's anatomy, looking at all the medical and surgical tools in the toolbox. But one of the challenges is with adults with Down syndrome is some of those devices, especially ones like CPAP and dental devices that require an external apparatus, can be very challenging for people with sensory issues,
Yeah.
challenging where you already have caregiver stresses and other medical behavioral lifestyle needs. Adding in a device like CPAP, where you have to have distilled water and a hose and a mask and new supplies and cleaning it and traveling with it, it's not easy. So it really sets the stage that we need to find other solutions that are easier for these patients and families to employ.
Yeah, I agree. And I think I'll definitely direct our listeners to prior podcasts that we've done looking at ways and techniques that we might be able to help kids and adults with Down syndrome to wear those CPAP devices, which if I'm understanding correctly too, on the adult side, it's hard even for adults without Down syndrome to keep that CPAP on as long as they should. Am I right?
100%.
Yeah.
Even in well-designed clinical trials around the country, it seems about 40% of people on average really use CPAP on a consistent basis.
Yeah.
That's in the regular general population, and even a population that's getting the right motivation and instructions in a clinical trial. So yeah, there's a big need to find different options. When CPAP works, it works exceptionally well in general population, Down syndrome population, et cetera. But when it doesn't work, we can't just give up and say, well, you just have to live with this and be miserable. No, there's other ways now that we can help these patients.
So let's talk a little bit about that because I think one of the things that I find when I talk about this topic in different locations is people always want to talk about the latest and greatest in terms of management in sleep apnea. And I know that there's been a lot of change recently and new options that have come out. So Ryan, can you tell us a little bit about the hypoglossal nerve stimulator? I know it goes under a brand name of Inspire. You hear a lot of commercials. If you watch sports, you see a lot of commercials for this device. What is this hypoglossal nerve stimulator? How does it work? Who can it help? Those kinds of things.
Yeah, so this Inspire therapy is something that dates back decades. So this is based on a lot of basic science research 20, 30, 40 years ago, and it culminated in the early 2000s of an implantable device. So you can think of it, although it's a lot more sophisticated than this, in lay terms, you can think of it like a pacemaker, but instead of a pacemaker to the heart, it's a pacemaker to the nerve that activates your tongue and throat muscles. So rather than that throat collapsing and narrowing, like Dr. Whelan described, the pacemaker device sends little impulses as the patient sleeps at night to add muscle tone and move the tongue out of the way, all in an effort to improve breathing. And so the early clinical trials on this were done about 15 years ago. We were one of the lead sites in the main trial for this here in Pittsburgh. And then our team did the first implants after the FDA approval in early 2014 and have really been leading a lot of the research along the way. Dr. Whelan now leads clinical trials in pediatric Inspire therapy for patients with Down syndrome. And so Pittsburgh, UPMC, Children's Hospital have really been leading the way. And there are now approximately 100,000 patients with Inspire therapy in the US. And it's really become now a very common and accepted alternative for patients who can't tolerate CPAP.
And we really are blessed here in the Pittsburgh area with this type of research going on. And I guess Ryan, just give us an idea. Has there been any data that you guys have found to show that this is helpful, particularly in people with Down syndrome?
Yeah, I think again, there's enough data now, hundreds and hundreds of clinical studies through trials and other institutions and registry databases that show that it provides a meaningful benefit. In our adult population, on average, people get about a 70% reduction in their sleep
Wow.
apnea scores, most often taking them from the severe range down to the mild. So is it curative? No, but like any condition, whether it's diabetes or asthma, we're not trying to cure, we're trying to improve people's symptoms and quality of life and try to lower or eliminate their health risks. And this therapy seems to do that in at least the majority of the patients. The data is even a bit stronger in patients with Down syndrome. And maybe that's because of the reduced muscle tone of the tongue and throat that Dr. Whelan mentioned as part of the disease process in patients with Down syndrome. This Inspire therapy might actually be best suited for those patients since
Wow.
that's what it's targeting is the muscle tone aspect of the problem, perhaps more than any other treatment.
That's great. And I love the fact that, adults with Down syndrome have been included in these earlier on in these trials and everything that have been going on the adult side. But Rachel, let's shift now for our patients in the pediatric side of things. Is this even an option for them? And what ages and who qualifies and how does somebody find out more about this? All that kind of stuff.
Well, like many things in medicine, things first get tested and make sure they're safe and tried and true in the adult world. And then we feel comfortable starting to move it over to the pediatric world.
Hmm.
So, actually, like Dr. Soose was saying, because this technology really focuses on the tongue, and we see so much tongue collapse in patients with Down syndrome, really driving their sleep apnea, that this was really the kind of light bulb moment for those of us that take care of children with sleep apnea and Down syndrome to say, this is probably going to be a great group to respond to this therapy. So because of that, we looked at the adult data and we really pushed, to kind of start studying this in children with Down syndrome. So over the past decade, we've really been implanting these devices in children with severe obstructive sleep apnea and Down syndrome and really studying them closely. And I agree, we're seeing similarly really promising results on the pediatric side. Because of this initial work that's been done over the past 10 to 12 years, last year the FDA actually approved Inspire therapy in children with severe obstructive sleep apnea and Down syndrome who are at least 13 years and above. So that was a really kind of exciting advance when it comes to taking care of sleep apnea in kids.
And that approval, of course, I'm gonna toot your own horns over here. That approval, of course, comes with all of the hard work and efforts of you guys and of the team around the country that's really been doing these studies. So kudos to you. Now 13 is great, but as we know, we're getting sleep studies and all these kinds of things earlier. The recommendations from the American Academy of Pediatrics get a sleep study for everybody by the age of 3 to 4, and so with Down syndrome. And so I guess. Um, is there a thought that maybe this might be effective even in younger kids that don't respond to the initial treatment options, or are we always going to be 13 and above?
That's exactly right. I think those of us that do these surgeries and take care of these patients know that nothing magical happens when you turn 13 to say, now you're going to respond to therapy. But, you understand the FDA is being as, safe and conservative as they feel that they should be. Actually, the kind of second arm of the current clinical trial, Pittsburgh is again one of the 5 big children's hospitals across the country. that's now starting to enroll patients. We're still currently enrolling patients that are 10 years and above, and really kind of looking at neurocognitive outcomes. Because, we know that the blockage in the back of the throat, the number of pauses in breathing, oxygen levels, those numbers respond to therapy. But we've had so many families also tell us that they just feel like daytime function, school function, energy levels, behavior are also better. And so we're trying to now kind of quantify those measures, because I think you could really argue that they are equally, if not more important, in terms of really quality of life and day-to-day function for our patients.
That's wonderful. Well, I think this has been a really great podcast, really educational for me and hopefully for our listeners as well to really understand the continuum between sleep apnea, both in kids and in adults. But I want to give you guys each an opportunity if there's anything else that you want to make sure that we discuss or any kind of summary that you would want to make sure that our listeners leave with. Rachel, I'll start with you, and then Ryan, we'll go to you next.
Thank you, Dr. Velody. I wanted to thank you again for having us on. It's been great to be able to talk with you this morning. I think the important thing to remember when it comes to sleep apnea is that, again, every patient is different.
Mhm.
And so there are exciting things coming down the pike. Patients may or may not be candidates for these surgeries. And so I would say I would encourage families to come and speak with, a sleep surgeon, a sleep medicine doctor. And, the other thing I'll say is that sometimes our kids surprise us. And so even though, adults with or without sleep apnea or with or without Down syndrome may have a hard time tolerating CPAP, sometimes our kids really surprise us. So every patient is a little bit different. We look at everybody as a unique patient.
I
So.
love that. And Rachel, my one of my favorite podcasts that we did a few years ago now is with a friend of mine who has Down syndrome. His name is Daniel, and he walks through how to wear CPAP for our listeners on a video podcast. So if you haven't seen that one, I think you guys would enjoy that one as well. Ryan, let me shift over to you. Tell me a little bit about you from your perspective. What would be something that you want to make sure our listeners hear today?
Well, I think for patients and families, particularly for this Inspire therapy that we talked about, I know we just scratched the surface here, but I wanted people to be aware that there's a lot of information on their website as well as the Inspire app that really explains more about what this involves. This is a brief outpatient surgery, but it's very different than traditional surgeries of the throat and jaw, meaning the pain, the recovery, the downtime, and all that is way, way, way less. So I want to make sure to make that distinction that even though Inspire involves a surgery, it's a reversible procedure. It's a lot different than surgeries of the throat and breathing passage. And I also wanted to point out that even though it still has a device that has to be used and turned on, that most parents and caregivers really find it much easier. What it involves is a little remote control that's clicked over the chest. There's nothing that they have to wear or clean. And so we've heard a lot of feedback from parents and caregivers that it just makes their lives so much easier where they can now focus on all the other aspects of their care and just stick with a click of a button for the sleep apnea. And then the last resource besides the Inspire website and information there, I wanted to point out that Dr. Whelan and I are both on the global organization for Down syndrome, their task force right now to update the guidelines for medical care for patients with Down syndrome. So I think that global organization is also a great resource, and you're going to be seeing over the next year or two updated guidelines come out for sleep apnea and all other medical conditions as well.
For adults, you're talking about the Global Down Syndrome Foundation, yeah, and we've definitely benefited from their ability to get folks together on the adult side. Where this is one area, Dr. Whalen, that we can say pediatrics. We've done a lot better job of getting guidelines out earlier on for people with Down syndrome. But it's wonderful to see our adult colleagues now too recognizing the importance of healthcare guidelines for adults with Down syndrome as well. Well, I just want to make sure for our listeners, I want to make sure that we all remember, we here at the Down Syndrome Center, we are here in Pittsburgh, very, very happy to help to organize the initial evaluations for sleep apnea, getting that sleep study done between the ages of 3 and 4 for our local families. But I know that most of our listeners are from outside of our area, so getting connected with your local pediatric ENT or pediatric sleep clinic is really, really important because that sleep study is something that is uh, one of those times where it's going to be important to travel, especially for our pediatric patients, to travel to a pediatric sleep lab and get these studies done because it's hard to have an adult sleep lab be able to do all of the correct testing and do it in a way that's going to be well tolerated from young people with Down syndrome. I think a pediatric sleep lab is definitely going to be something that would be helpful to get connected with. So your local pediatric ENT or pediatric sleep clinic can help. Dr. Seuss, when you guys are recommending sleep studies, let's say for an adult with Down syndrome, are there specific places that you recommend, or do you just kind of get the feel of who does those studies well with our adults?
For adults with Down syndrome, we use either in-lab sleep studies through the UPMC system, or it's actually much more common now to use home portable testing. I know that hasn't become as approved and regularly implemented in the pediatric population, but in adults, general population, probably at least 90% of our patients do home portable testing. And again, especially for folks with sensory issues or challenges, being in a lab environment with 15 wires on is very difficult to sleep, which is the very thing that you're trying to test.
Yeah.
So there are tests now that can simply be worn on the finger or on the wrist. It can give you the sleep apnea information that you need, and it can be done right in the comfort of their own bed.
Wonderful, thank you. So get that sleep evaluation done for the pediatric patients, and if you're having an adult with Down syndrome who's having any symptoms, of course, reaching out to your adult providers to be able to get these types of studies done, hopefully at home, which sounds like a really great option and much probably better tolerated than being in a sleep lab. Well, thank you both, Dr. Seuss, Dr. Whalen. Thank you both for being a part of the podcast today.
Thank you, Dr. Velotti. Really appreciate your time.
Yes.
Thank you so much. It's been a delight.
Wonderful. And to our listeners, thank you for being such fantastic listeners to this podcast. We are nearing 300,000 downloads to the podcast here, and it's really exciting. And really excited also to be able to provide this information to you all. So please do reach out to me at Down Syndrome Center at chp.edu if you have any topics that you'd like us to cover on the podcast. And for those of you who are able to support what we do at our center, including this podcast, please go to givetochildrens.org/Down Syndrome Center. But until next time, bye bye.